Good afternoon, everyone. Gareth Presch, founder of the World Health Innovation Summit. Delighted that you can join us this afternoon, Friday afternoon. I hope you've got a cup of tea in front of you. I'm joined by Dr. Tom Ashfield. Tom, give the audience a quick insight into where you're joining us from, and maybe a short background.
Right now, I'm in Bristol. So yeah, it's been a week. I was in London this week for the Longitude Prize, missed my train home. So I stayed in Didcot Parkway for 6 hours. That's been my week. So I'm a little bit tired still. So yeah, I'm joining here from Bristol, and my background is as a clinician, but I've also worked in industry. I was a pharmacist prior to medicine, and I still work as a GP. My specialism is within antimicrobial resistance reform and equity and access, really. So yeah, really pleased to be here.
Fabulous. So just set the scene for everyone who's joining us on LinkedIn, Twitter, and by the way, we'll have a couple of minutes at the end where we'll take some questions. So please do pop them in the chat. I guess this sort of series of webinars that we're hosting this year is going to really look at new models of healthcare. Today we're going to talk about evidence, and evidence is everywhere. I guess just to set the scene for people who are tuning in, we do face enormous challenges in the health system. By 2030, estimates are around 10 million short in terms of staffing. We've got a rising population. We've got another 2 billion people. But again, that's an opportunity. And then if you look at globally, 3.5 billion people don't have access to healthcare. So we're very fortunate here in the UK. We have the NHS, but there are a lot of people around the world that are not as fortunate as ourselves. Recently, I was in Helsinki at the Radical Health Festival, and we were setting out our mandate, sort of our future plans, which is to give people the tools to manage their own health and well-being. And I truly believe that we're going to see a pivot in how we finance healthcare in the next couple of years, from the current model, which is managing disease, to prevention at scale. And I think that's very much evidence-based. Tom, maybe a couple of words from yourself. Maybe you could set the scene, give people an insight into the huge challenges we face from an AMR perspective, and maybe people infectious diseases, they will be familiar with COVID and the impact that had. But also, I want this to be a very interactive session between myself and Tom, so we'll be pinging questions back and forth between ourselves. But over to you, Tom.
Yeah, indeed. Well, I think let's take it back to why we've called it Standing on the Shoulders of Giants, right? So I'll just come straight back to you. Who are the giants that have influenced where you're here now, Gareth?
Oh, well, appreciate. Yeah, I mean, for me, it's Professor John Bonner, and he was really the giant who shaped my career. He was the chairman of the National Haemophilia Council. I spent 7 years under his stewardship. He was the one who put the structure around how I operate, and I owe a lot to him. I mean, they're great people. I've been very fortunate to meet a lot of great people. And from a patient's perspective, I worked with the Irish Haemophilia Society, Brian O'Mahony. These are pioneers, and they really shaped how I see the healthcare system.
Indeed. Yeah. I mean, for me, I guess the giants that I'm thinking, I have to sometimes separate that from the musical world because that influences me so much, even in healthcare. But I guess healthcare is without a doubt Alexander Fleming. His empirical approach, his ability to observe and not have the technology, and then just sit with the story. And he predated this with the opiate story already, way before anyone was talking about stewardship. So stewarding healthcare and getting the right access to technology, I'd say he's there. And then Jon Snow, not of Game of Thrones or Channel 4 News, but Jon Snow of Soho, the founder of epidemiology and contact tracing. We are in this country the home of contact tracing. We should have realized that. We had that already. So yeah, in terms of, that brings me on to bugs, right? And saying evidence is everywhere. They outnumber us even in our own body, so we have to take them seriously. If a pandemic wasn't enough to tell us that that's the case, then the threat of AMR, which is happening right now in Southmead, probably just over the road, and the BRI down there, to everywhere around the world, it's impacted right now. And so as we understand that the bugs are ubiquitous, they give us the keys. They tell us where inequity is. Your postcode does not tell you where inequality is. It sort of helps, but it's not useful. However, where the TB sits, where the outbreaks of illness are that are communicable diseases. It tells you every single time. So as you monitor that evidence, you get a whole realm of non-human data. It's so wise. We see in the papers today around the water. People are in settlements because of water supplies. That's the only reason people settled in places. If you survey the water, just like many of the greats have done, you find the medicines. They're on the trees. They're actually found in the sewers. Cephalosporins were found in the sewage. So we've probably got a lot of drug discovery going on at the bottom of these as well. So yeah, the bugs, I think they are also the giant in terms of number that teach us a great deal. And as we saw in the pandemic, in the wake of that, we have a dashboard, which was wonderful. But really, when I start my clinical shift again on Monday, I need to know when the last whooping cough was and where it was to influence my day to day. And I need a dashboard for that. So yeah, I think we've learned a lot, but we've got a long way to go.
Yeah, and this, like, the evidence is everywhere, So one of the things when when I'm traveling around the world and I'm in a certain jurisdiction, you always look at the demographics and kind of look at the evidence base. My question to you, Tom, are we measuring the right things?
Wow, that's a really fascinating question. Yes and no. And some we can't see yet because we don't realize there'll be undiscovered approaches. So one of those things is the we within that question. Who is the we? Who's saying? Who is the dogmatic, leader of this? Probably nature. Probably that's going to tell us. The science, the people are going to tell us. So in terms of what we're measuring, I think we miss out a great deal. But we are making progress. So in terms of equity, in terms of diversity, that in my job, that's just the person in front of me each time. It's how are you? It begins with 3 words, which are how are you? And then you go into that. And then you find out stories, you find out narrative, and you find out a huge amount of things that can influence innovation. I've innovated something off the back of one patient interaction, and many people have. That's where it all starts.
So here's, let's follow up on this, because I think this is really important from the evidence perspective. So let's look at the evidence out there at the moment. So I think yesterday we published over 7 million people are still waiting for surgery in the UK. Okay. And we have, millions of people suffering from obesity. And we have all these, non-communicable diseases, cancers, basically we've staffing issues. Now, if we're going to get ahead of this, we need to start to sort of plan long term. And I'm always being told, it's a 4-year cycle, 4 or 5 years, because it's a political cycle. But we have to be brave enough to kind of say, look, we need to actually put a bit of foresight in here and look at the evidence, because the evidence is actually telling us we're spending over 90%. Actually, I think it's about 98% of the budget goes into managing disease. And yet we get these outcomes. So, Tom, at what point do we say, hang on, we're getting it wrong here? We need to actually come up with a fresh approach. Because when I was in Helsinki, I was outlining this new approach where we can shift the model. And I was showing the evidence, £1 invested, 36 back. And so if you look at the opportunity cost from an investment perspective, you have trillions of dollars being invested in a sick care model, but being able to take that evidence and use it in a more productive way, surely that's the future.
Yeah, I totally agree. So I think the thing to wrap around this is the UK delinkage model, which I'm a huge fan of. I was involved in that. And this is where we delink the volume of medicine used from the outcome that's achieved. Now, if we're looking at antimicrobials, that's life and death, right? But it's not just life and death. It's opening a hospital. It's existing to do your chemotherapy, to do your surgery. The enablement value around the data, around all of the evidence that we have and the technologies that we have is so important. So only if we look in the right place will we reveal that value. There's so much value, and you talk about this. It's unpicking where that value is. So that's not hard. And we've shown that in the UK with the delinkage model, that it is possible. But it was hard because the evidence was geared to clinical trial data, and it has to be because that's what we've got. But we must think clinical trial data was born out of the age of cardiometabolic disease and oncology. So if you try and shoehorn precision medicines or precision approaches or value-based outcome approaches around something it wasn't designed to, you won't find your value. You won't find your value. So your value lies in outcomes. How do you help outcomes? You have very good approaches. You have an informed society that understand how to access the care. You have accessible treatments, and you also prevent people getting to that. And then you can realize the wider investable approach to this. I'll again use infectious diseases for this, but it significantly impacts security, our biosecurity, our biodiversity, our pension security, our food security massively. It's so investable and it's so clear. And what it does is it completely tethers to outcomes. So really, to conclude, I think we've got to look at outcomes. And as you do that, you untether from all of the things, thinking, how many dressings did I use for that? And go, oh, actually, sometimes I need 10, sometimes I need 1, but the patient is well, right? That's definitely the way to be.
And I think it's like, so we need to understand as well. And we know this. Look, if you've got a chronic illness and you're attending, say, for cancer treatment, you're an oncologist, you'll only spend maybe 1% of your year with that oncologist, probably even less than that. 90% of the time you're out in the community. So what impacts your health and well-being will be that interaction with the community. You can also measure that. You can measure everything, time, money, it costs. Everything has a cost to it. Nothing is free, as they say. I think we're on a good trajectory. I think there's an opportunity here. I think when you mentioned about the evidence, and this was what we called for, and I was really delighted when you said about the pension funds, because they're critical here. So are the sovereign wealth funds. To be able to enable these big changes to happen. I mean, at COP 28, we put a declaration together. We basically, because I came up with this concept, Tom. It's interesting when you mentioned the pension funds. When I worked with the Irish government, I was, chief officer of the National Haemophilia Council, but I never had a clue where my pension fund was. Not if you had asked me, I wouldn't have known what it was invested in.
Were you in Ireland at this point?
Yeah, I was in Ireland at this point. But what happened, as over the last couple of months, over the last few years, I've started to work with it in the investment side. And I began to ask questions around, well, where is my pension fund actually being deployed? And then I realized when I was in Ireland, I just got my paycheck at the end of the month. And that was it. I never looked at where that was actually being invested. And that's where I came, I see in the declaration from COP26 around, healthcare professionals, they made this incredible declaration about climate change being, the basically, it's the biggest single health threat facing humanity. But it's nice to have that in words, but what about if we could mobilize 1% of the pension funds from the health sector? That's where I came up with that concept. I was like, hang on a second. We know that we're facing these huge challenges that are coming around the corner. We need to release capital, new means. And that's why we set up the World Health Service and our 5013C and our investment structure, so that we can now work with pension funds and investors so they can invest in bankable projects. That's where that concept came up. That's where, and we have the evidence. That's why it's not difficult to foresee where we're going. We can actually
sustainable. It's sustainable investment, right? It's
exactly.
There's a lot more surety in it. It's not vertical aid anywhere in the world. It's you see so much collateral benefit. We got to think about all of the advances in science. If we stay in siloed thinking, in risk-based thinking, and in just channels of saying generate more evidence, go and seek data, we miss the opportunity where there's a whole swathe of population that are really engaged in it and saying, oh, I'll give you my information because you're doing that. People are doing it all the time. They're doing it in their supermarket with their loyalty cards, right? They'd sooner do it with their healthcare. So I think we need to embrace the citizen. We need to move to citizen science. We're learning a lot about that, right? You put those in the picture, you bring that. We must have really good service design as well, because unless you've got a well-designed service, you won't pick up the evidence of what works, and then that iterates for you to get a better service. So we need to be very holistic in the players that are in the game now. Thankfully, I now work with people from all over, the world from all angles, patient advocates, and yourself, economists, engineers. And it's, that's the diversity you need to make change for any problem.
Well, especially in healthcare, because it's such
absolutely.
a big problem. It's like there's nobody, anyone who's watching this, will have a family member who at the moment is probably going through some sort of treatment. It affects us all. Health is wealth. I think that's what we have to get our minds around as well with the economics that we face at the moment. Difficult choices have to be made. So we have to ensure that whatever government is in power, prioritizes health and well-being, because if you're not fitting well, you don't have a job, and then you can't be economically active. I mean, we've seen with COVID the impact it had on our health and well-being, but also from the economic perspective. I mean, there's wider, shall we say, stakeholders at play here. There's so much to learn.
Yeah, I mean, I think the term enlightened self-interest is much more applicable than corporate and social responsibility, because that implies a passive role, when in fact, if you put those resources behind something, you will definitely get a return in every way, in terms of your people retention, your productivity. You'll have findings that are collateral findings. You'll be investable. So really, I think coming away from a lot of the semantic and the channels we're in, and that's where we also come to hierarchy, right? With evidence, we talk about this hierarchy of evidence. Now, my hierarchy of the best medicine or the most novel medicine in the world, it's actually about time. So if someone has sepsis right now, that medicine is the most valuable medicine to save their life. But on Tuesday, it isn't. It's not even worth it. So it's about time. And this is where we need to bring that in. So access and time make it valuable, and then it's investable. If you don't invest soon enough, you lose that time, you lose access, and then it becomes a biological risk or an investment risk, and it so isn't. So what are your thoughts around this? And in terms of the numbers of return on investment you mentioned, Gareth, how's that sort of come about?
Oh, well, I mean, I used the same sort of modeling that I used when I was writing business cases with the haemophilia groups in Ireland, like, so I was very astute to what was needed, shall we say, from the government's perspective.
Did you manage the infected blood scandal there, right? In terms of
yes,
policy?
That was, the National Haemophilia Council was set up after the Lindsay Tribunal. So my role was to advise the Minister for Health on all matters relating to contaminated blood products and HIV and hepatitis C. We managed it very well, and I got the insight how to work with clinicians, and also to work very well with patient groups. And of course, being a policymaker myself, it was a fantastic opportunity. What I really learned from the whole experience was, that we could create value together. I think too many times when you work in the public sector, you're very much around protecting the state, where you should be allowing and enabling things to happen. There was one point I wanted to bring up, though, around what we were speaking about in terms of like the opportunities. I think like healthcare is in a unique position because it's apolitical, and everyone can be a winner. But when you talked about the business community and that, I think we have to understand that the future of business will be aligned to societal value. I will only buy products that are actually doing good. And that's where I think the likes of the World Health Innovation Summit as a social enterprise can be the future. And we can replicate these models. Like, I personally only want to support businesses that are doing good. I think it's even more essential now as we move towards these climate challenges, and we want to see products and services that are actually good for our health and well-being and do good for our planet. Certainly from my daughter's perspective, I have 2 young girls, I know they're very active in this space, that they will only support companies that are doing good. And I think that's a lesson, and that's an opportunity for investors.
And what does it also show? It shows that it starts at home, right? They won't have had that attitude unless they had parents or environments around them that taught them that. So it's very straightforward. You adopt and spread. I learn a lot off of younger people all the time. It's so important. It's their world. It's everyone's world. We need to understand that the insight, is literally everywhere. And that's something I sort of think about as well, that if we only channeled on evidence and data generation in this passive way of grabbing or scraping from other things, we miss so much, and it's so valuable. And people are embraced. We actually ran a citizens jury in Liverpool when I worked at Pfizer, and it was so revealing because people were really invested in the problem in Liverpool. They were saying, well, actually, no, we want we're fine with this data being used in many realms. It's about the use case, and when you can then tether that to a rational outcome. And enablement, you mentioned that word, and it's so important because that's where all the pockets of investment lie. You can't have services without the other things that are enabling them, like your water supply, your foundations of your hospital, your building that you're in, infection prevention. That's the first thing. That changed sanitation and infection prevention, changed our outcomes. So we still need to value that, almost like Maslow's hierarchy, and say, without this, you don't have your precision medicine, you don't have your new chemo. But when you also start from that, you can apply it across the world. It's so important, and it fits with the WHIS approach, I think.
Yeah. So, I mean, look, our aim is to give people the tools to manage their own health and well-being. And I think we just talked on it earlier. We touched on it earlier, around, the access and the information that's going to be out there. One of the things that I mentioned to you when we were working in haemophilia care, which was evident, was if you gave people the choice, so we used to give them their medical records on a card, so that they could inform the doctors that they had haemophilia, for example. 9 times out of 10, they would give you that access, so it's just that explanation. I think we need to do that. And we've got a couple of questions. We've got a couple of minutes left. We've only got 3 or 4 minutes left.
Let's go for it. Yeah, many thanks.
So the first one is like from Dow. How do we get the evidence of outbreaks quickly enough to healthcare workers to make a difference? I think this is specifically around infectious diseases. So, Tom, this is a good one for you.
Yeah, well, I guess it makes sense to do that. The thing is outbreaks. So if we think about MRSA, when that first was happening, you'd call it an outbreak. When it becomes endemic, it's then a problem, and then you either incentivize to do something about it or you don't. So what we need to do is change the narrative, because it's about carriage. So a lot of the stuff, the potential outbreaks, come when we then put people at risk of invasive illness. So when we subject them to necessary surgery, necessary chemotherapy, hey presto, the things that they're carrying in their gut from the environment come out and they translocate. So a lot of them are just in us anyway. How do we inform healthcare workers? I think that we've done amazingly well already, but I think that if that were the case and we were doing it fully, we would have aligned practices of stewarding in every single case of an antibiotic, that you treat it like a scalpel. If you're not thinking about it like that, then you're not fully thinking about the infectious diseases. So it's really about your action, your outcome, and what you're doing. So your stewarded outcome and access to care, I think, is important, and disseminating it in the right way. ICID is a really good point of this. Detected the Wuhan signal. The International Society of Infectious Diseases, they enabled people to know about this, right? It is huge value, but we don't always know about it. And it's a bit like the ticker tape, the Bloomberg ticker tape, like, that exists. You can find out what's happening in Minneapolis right now, or in Hounslow in London, right? You can, it's possible. We just don't know about it.
I think it's very difficult, though. It is very difficult because we, and I think it's very difficult for politicians as well. I think we have to acknowledge it's very difficult to make these decisions because they're, they have a huge impact on our whole way of life. So we have another question in here from Kieran. Do we concentrate too much on management of infections and not enough on diagnosis? Well, that's a great question.
It is, but are you okay to go with that for now? Because I think it's really good.
I mean, certainly I would say yes to answer the first question, and we definitely don't do enough on the diagnostic side. I think what we will begin to see, I mean, there's so much pioneering work going on in diagnostics at the moment. The worry I have and the caution I would have, because we can diagnose diseases early, right? We can do that. That's not a problem. The problem I see is the overwhelming of the health system. Because we can go in too early, but who's going to treat these people? That's the issue I would have, Tom. You know, I know a lot of companies, and there's a lot of technology coming in. You know, if you look at like, you know, some of the work that LG are doing at the moment, you know, you're very soon, you know, they're launching new products at home. You know, you're going to have TV devices where you can basically have everything at home. And I think that's fantastic. But the problem is going to be who's going to treat these people, because we just do not have the staff. And we do not have the capability or the capacity. So that's my real worry here, Tom. I think the system could completely
I think you're right.
overwhelm.
And I think you're right. We learned when I was at medical school, we learned something called Wilson's criteria. This is the criteria, an empirical view, which I still believe in. It doesn't need much evidence of how you put screening in. This, you know, this is slightly, you know, another track to diagnostics. But what it does embrace is thinking about something called the pre-test probability. So that's just your thinking. That is also in the population of how they present to you and the words that they've got to tell you that they're unwell. So you can only employ the right diagnostic if people are telling you the right things in the history and they're showing you something like a fever. But what was also really fascinating is you need to also have the same threshold of doing it. So if your threshold is not the same between people, then the value of that diagnostic is lost, and it's done at the wrong time or in the wrong people. And then it might get maybe a bad rep when it was a really good thing to do in certain circumstances. So service design again, this is where our behavioral scientists are essential. Kieran who asked the question here, Kieran pioneered microguide, and that was putting antimicrobial guidance in the palm of people's hands at the outset of apps, really. I think it's incredible. And when we've got peripatetic doctors, which is everyone, they work everywhere often, you know, rotating, you need a consistent source of what do I do in this area. We recently did some work looking at hospital-acquired pneumonia, not from the perspective of the diagnosis or the treatment, which, you know, there's really good alignment. We actually got great practice. But the threshold of what we call hospital-acquired pneumonia within the same city at a different hospital is different. So if your thresholds of just what you're calling it in your evidence-based guideline are different, then you'll end up doing things differently. So really, really important. We must focus on diagnostics and they must be available. So when I'm in my GP practice, I need, you know, the longitude prize happening the other day, but I'll need probably a room for the diagnostics. And there's not a room for even to recruit another GP or physician's associate or nurse, right? So what do you do? So it comes down to infrastructure and having the room. But fascinating question. I could talk about it forever, but I don't want to bore everybody. So
yeah.
Great.
No. I think we're coming to the end of our session here. This is just to whet the appetite, really. I mean, this is the first of 4 sessions for us. Just a comment that's come in from Mary. My thoughts exactly, Gareth, from surveillance to diagnosis, treatment, and follow-up support. Workforce development is key. Like I personally think we've got a huge opportunity to create millions of new jobs in a preventative model of healthcare. And I think that leads us nicely into our next sort of discussion, which will be up. We're gonna look at highly investable opportunities within sustainable healthcare. That's on August 2nd, for 1 p.m. Then we're on progress, marching towards supply chain fidelity, August 30th. And then our last one is enablement. What does value mean for citizens, communities, investment, and industry? That's in September. 1 p.m. You can join us all through our website and on LinkedIn. Tom, I just wanted to put some final thoughts from yourself. You know, are you excited for the rest of the series?
Absolutely. And what I'm most excited about is having met you, Gareth, because it hasn't been that long, right? I've known about you, but what we really align on is our values. And that informs what you do, because we came up with those 4 very quickly, and we were like, yeah, that's the right one. So I'm fascinated to see where it goes. I'm really liking the community that we're garnering on LinkedIn, which was something 10 years ago when I was working in healthcare alone, I wouldn't have really thought about. I think when we're garnering a really good health and social care debate and dialogue on there. So yeah, and for you, what are you hoping I guess it's worth sort of saying after after Helsinki, what's happening for WHIS in the last minute?
Yeah, I mean, I'm very excited. I mean, I caught up with Ben Wilkins this morning. He's a good colleague of mine. We're working together on MSK. I'm really excited. You know, what's been happening with us, I mean, I'm starting to, you know, build bridges with investors. It's very exciting. You know, we sort of, if anyone has a chance, take a look at World Health Service. That's sort of our not-for-profit funding vehicle that we set up in the US. I'm working with Montcalm. They're experts in terms of impact investing. Being able to talk to like sovereign wealth funds, impact investors, pension funds, you know, these are huge opportunities, Tom. I mean, you know, I was at a recent event with EBRD, you know, Professor Dame Sally Davis kindly invited me to an event with the EBRD, and the opportunities are enormous. And I think having that wider holistic approach, working with the business community, working with local communities, what an opportunity we have, you know, especially
about that very day, Gareth. I'm actually writing a paper and presenting it later in the year in Cape Town called Reasons to be Cheerful, because the impact investors have taken a quantum leap in understanding in this, and they're leaving people in the wake. We've got a huge amount to learn from them. So I've learned a great deal, and that was a really good day at the EBRD. Yeah.
Well, look, we'll wrap it up. Thanks a million, Tom. Enjoy the weekend. I mean, I'm glad you mentioned music. This weekend, I'll be going to a concert myself, the Foo Fighters in Manchester. So I'm looking forward to that. And that's good for your health and well-being. So look, everyone who's out there, thanks a million for tuning in. And we've got some great comments that's come in here, like Grace, thank you both, from Mary as well, and others. Thanks to everyone who's joined us, and we're looking forward to working together, building sustainable healthcare for the future, giving people the tools to manage their own health and well-being. You'll hear from myself and Tom again. As I said, we'll be back on the 2nd of August, so do stay tuned. Thanks, Tom.
Right.
Talk to you soon.
Thank you. Bye then.